So I guess to start, some important notes are really to emphasise that good paediatric palliative care is actually very good paediatric care in general, and that's the first step, and then a few things will get added on to that. Holistic care is essential, and we've heard that from a number of speakers here today, which is good. It was in my talk before that. And attention to detail is essential, with very good assessment skills already iterated by other speakers as well. And that paediatric palliative care nursing is definitely a privilege, to keep that in mind. So some of the challenges are that the needs of these kids that we're seeing now who are reaching our service in paediatric palliative care have survived numerous rounds of oncology therapy, complex because they've survived the NICU environment and have chronic lung disease. Their parents have met a lot of health professionals. These children are surviving chronic illnesses that previously, even in India, they would have succumbed quite some time ago. So their needs are complicated. Their physical care needs can actually be quite heavy, and you can unpack that as much as you like. Sometimes they're steroid affected and their physical weight is heavy. Sometimes because they're surviving longer, they're not neonates when they have these complex conditions. They're now 7, 8, gangly. They're well nourished because we've taken such a good job of their nutrition, and so physically nursing them can be quite difficult, as well as wound cares and other complications. We all want to involve the family and the community, and we've heard already how do we include the siblings and extended family, perhaps a very extended community if it's home care. There are a lot of emotive factors in caring for these children, and that's us being human. But the loss of a child is not as it should be in the world. There is a chronic grief for some of these families, and the distress of the families is marked at times. And certainly as health professionals, we talked earlier about the distress from primary teams and times. And as we've heard already today, that it is about being human, and yet we need to remain professional. So as the nursing group, this can be a challenge. Specific challenges might include how to understand the purpose and benefit of any interventions that are prescribed by other healthcare professionals, or even in what are we doing as a nursing practice. Our medication management can be quite complicated. We need to understand the use of these strong medications, identify the fears, the myths, and be familiar with the dosing and what new products are coming to be, as well as their delivery methods evolving in different situations. We want to be able to predict symptoms and manage them in a timely fashion. Wound care might be complicated with pressure areas or cancer wounds. And certainly, as a nursing team, we do need to understand the dying process better. So one of the biggest challenges I find even in a tertiary centre is what to do or not to do. Interventions like blood tests, and even down to, we have a lot of technology available to take a pulse or to take an oximetry. So we take all the machines in because that's what nurses do, we do stuff. And so we can't help but go and use the machinery available to us, to the technology. But is that the best thing to do when we can gain just as much information from a manual pulse, measuring a respiratory rate? And what do all the other numbers do if we're not escalating care around that because the child is reaching this point closer to their end of life? We might want to consider how we plan and document care provision. Some of the care needs for these kids is quite complicated. They may be non-verbal, not able to tell you that they don't like lying on their left side, their right side. And if their parents are in attendance, they can guide you, but sometimes they're not. So how carefully do we document this so that we're meeting the comfort needs of these children on every shift of every day, not just about the nurse who's familiar with this child's care? How do we then assess their pain and other symptoms? And other speakers have spoken to that today, using more objective tools, not the predicament that Jean spoke of before. If you're 3 out of 10, you don't get, you have to be 3 out of 10 to get Panadol, 4 out of 10 to get something else. Being a little more flexible than that, but using the BARF scales so that consistently the medicine is delivered with an objective approach so the child doesn't suffer on one shift worse than another. And we certainly want to record our interventions and the medications we did use so that we can see a pattern. When the doctor does the round in the mornings, we can report, well, when we did this, it lasted for 2 hours. When we did this, his pain and symptoms were controlled better for 3 hours. And that will help inform the rest of the team to make changes to the child's schedules. Medication management, we're talking a little bit about these in different sessions, and that the stronger medicines such as your morphine, your midazolam, fentanyl, they certainly need to be respected, but please use them. Even in our case study this morning, people were worried about giving morphine to an infant who will only survive 2 weeks. But the infant, his marked breathing and dyspnea, respiratory distress is marked, and it will be distressing for all, as well as, if anyone's met a child with respiratory distress, the look in their eyes as they look up at you. You're trying to avoid that panicked look. The morphine will not hasten their death, but it will keep them relaxed and more settled into the symptoms that they are managing. So it's up to us as the nursing team to be aware of these meds, how to manage them, how to handle them, and what route of administration might be best for that patient, and that can be very helpful. You'll also be the one who is presenting to the family. You'll be unpacking the myths and the fears that the families have of these meds. Oh, I can't give morphine because in my world the child is meant to suffer, it's part of his disease, and you might need to explore that with them a little bit. He'll get addicted to morphine if we start it. We've already heard, how do we address that myth? And it's a myth, and the literature tells us that the children don't get addicted. They do have a requirement, and you can't change their respiratory drive if you're matching a pain. All of those things that you'll have to explain to the family because you're the ones they're giving the medication. I hope that sort of makes sense. We also want to have timely symptom management. So that for us means that you do have to have an understanding of what disease you're dealing with. So the parents always, you're trying to build rapport with parents, sometimes in a very short time, sometimes over a longer time. But if you understand the disease, you'll understand the trajectory, you'll understand what symptoms you're going to be expecting to see. Therefore, and when you counsel the family about, I think his vomiting is only going to get worse from here because he's going to develop a gut obstruction, the parents have got a warning shot. And so then when things get more troublesome, you're able to work with them much more closely and then introduce the medicines as required or the non-pharmacologicals and gives them a warning shot about what they can do differently. And certainly the families, you're trying to set these families up for a long bereavement journey after the child's death. So anything you can do to help empower the families, warn them about the process of the disease for the child is very helpful in their whole story. And again, we talked about using assessment tools such as the revised pain scale, maximising your non-pharmacological strategies, and that's something that you can do very well and incorporate the siblings. So the child may have some edema in his hands and feet, so you can put a sibling on each limb and they can do a little hand massage. They love that. They like being part of the story. The siblings can paint their nails. You're trying to incorporate those non-pharmacological strategies and use the whole family, which is actually quite hard work to do that. It takes more time, but definitely worthwhile. So you do want to understand the medicines and their roles. We've talked a little bit about that. And when you explain things, then you are involving the family more in the choices. So if they prefer a particular oil or a blend, you can have them fetch it from home and bring it in so that you know that might be helpful. When you're including them in the choices, you're helping them parent this very sick child, incorporating everybody's care. And as the nurse, sometimes it's way easier just to do it yourself, to help make the bed or to give the child a wash, but to help the family do it is setting them up for a very a loving relationship that they keep connected with long after the child has died. Wound care in palliative care can be certainly very challenging. We are fairly lucky in that we don't see wounds in children half as much as we see in adult palliative care setting. However, here in India I'm aware that you see children with late presentations and a lot of wounds that are difficult. And so how do you do that? You certainly, in the first place, avoid some of the wounds with try not to use such aggressive dressing methods. You're going to use use your dressings to keep the wound clean and free from secondary infection. That's true, but the wounds are not going to improve. So it's not that you're trying to be aggressive dressing management, because it won't change how it is. The odour may occur despite your best dressing. So what other strategies do you have in your unit that you can control odour with? Some antibiotics topically to the dressing wounds can be helpful. Otherwise, usual herbs and oils impregnated in the dressings or in the rooms can be helpful. We also know that if the child is able to eat and drink, as spoken by the previous, your optimal nutrition, to the best you can, will prevent your pressure areas from being more trouble, and it will enhance the wounds to be the best they can be. So ideally, optimizing nutrition has those benefits. If you have access to a dietitian, you can engage them in that care. The cancer wounds are often very painful, so be sure that you're using adequate pain relief around those dressings, or the wounds will cause more distress than they already do if you're having to come in and they're difficult to manage. Bleeding can also be a potential complication, so make sure you've got a plan up your sleeve if the wound becomes a bleeding risk. So you can use the tranexamic acid, you can use the well-controlled bandaging, or not changing the dressing as frequently as otherwise. So if you have an understanding of that, it won't be quite so difficult to manage. Again, talking to the families about why this is. Before we change the dressing every day, now we only change it every 2 days. Because, and why is that? And I think it's important that as the nursing team, you are the ones who are there 24 hours a day. You are seeing the dying process, and you see it and you recognise it. We don't always are able to articulate it because we see it, but we're sometimes not scientific at putting our finger on it. The literature now describes the different phases of dying. Not too bad if you do a bit of homework around it. So I picked out the major points that we could address today. So acknowledging that the clinical signs, the physical signs of dying, are always intertwined with the psychological issues, the spiritual issues, and it's more complicated than just a change in his pulse rate or his respiratory rate, his colour. There's a lot more to it. The early stages of dying often are more subtle, and sometimes the parents or the child will detect that before clinicians do. So the most notable thing is their fatigue is more noticeable. So suddenly, even if they're on heavy oncology treatment or they've had cardiac interventions, all of a sudden this kid who was coping with therapies and things before is suddenly more fatigued, and he says, "I'm just so tired now." That's some of the words that you might hear. That is a warning shot to us as clinicians that this kid is probably undergoing some changes, and perhaps this is a prognostic sign for where he's up to. This can be weeks to days out from death. However, it is always a warning shot. So then we might lead into the more pre-active phase of dying, is what they call, is where the child is often becomes more withdrawn in themselves, no matter what their age group. This is across all the ages. You'll find the child just less interactive, more intriguing in himself. He doesn't want to see his extra friends from school quite so much. He's not as keen for visitors, and he or she may state at this time that I am dying. He may actually use those words, and he in himself has got this protective bubble going on. The active phase of dying is where we all recognise that, where the physical signs are evident. His colour is changing, his conscious state changes, his vitals become very compromised, and he now may not be able to communicate with you, so you may have missed changes. With imminent death, we often say to the families, he said, well, how will I don't want to leave him, I don't want to go to sleep, he might die when I'm not there. And we talked about that a little bit in the case studies this morning. But you know what, for most times, the kids often give the signal to a family that they are imminently dying, whether it's they're agitated, or they do use their words, or they're looking for somebody in particular to settle. That's a very positive sign amongst physical signs that his death is soon. And then the literature describes that post-death phase, depending on cultural considerations, what that needs to look like. So self-care, and Hanif will talk some more about that. I guess to reiterate that as much as we do this for our everyday job, that we do paediatric palliative care, and most of our children will die in our care, it's okay to be saddened by that. If I'm no longer saddened by it to a degree, I probably need to be driving a tuk-tuk or something different, okay? Because if I don't feel it, I shouldn't be doing this quite so much. However, how do I keep it in check? I may need to increase my usual care strategies. If normally a 5-kilometre run is good, and I need to do 10 maybe, and to keep it in balance. And if I need to speak with my family or friends more, that's okay. If you're working with a team and your team care is very good, it will enhance resilience of your whole team and yourself as an individual. As a team, it may be helpful to have a brief pause in time after the death of a child, whatever that looks like in your work team. Lots of teams have different strategies around that, but a brief time, even at handover or your big member team meetings, that you acknowledge the child's death, have a brief pause. I think that's a very good strategy. And to reiterate that looking after these kids and adolescents is certainly an opportunity for your professional growth. It's not just a difficult day. You can usually take something away from it that enhances the care of your families going forward.